And my name is Sten H.Vermund, as you see from, oh, well, I don't know what I'm doing wrong here. I tell you what, I'm going to shut off this. I muted the BlackBerry, but I'm going to shut it off in hopes that maybe that's part of why we're getting the feedback. Look at this. This is like, I got the one here, I got the one here, and I got the one here. This is a real odd, I'm wired today. Anyway, I'm a pediatrician by training and also an infectious disease epidemiologist. An epidemiologist is someone who just studies the patterns of diseases in populations. Demos from the Greek having to do with the populace, and ology, the study of. So anyway, epidemiology is what you engage when you're worried about an epidemic. Same root derivation, right? Epidemic, epidemiologist. Because you call the average doctor when you as an individual are sick. But if you've got the entire plant that's sick, or the entire cruise ship that's sick, or you've got a global AIDS pandemic, there's just so much that the clinician can do, and you have to get into the field of public health, which is where you dovetail into epidemiology. So I'm going to talk a little bit about, and extremely informally, I mean, can you get any more informal than Senior Day? I mean, it took me a while just to find a tie. It's today, I just wasn't going to wear a tie, but we're going to talk about saving lives from AIDS in Mozambique and Vanderbilt in rural Africa. I think the organizers of Senior Day thought I was a little bit of an oddity, so it might be fun for you to hear what we do on the global front. By the way, I'm not an oddity here at Vanderbilt. There are many faculty working internationally. Dr. Demarest is an internationally recognized archaeologist who's been working in Guatemala for 28 years. Tiffany Tung, who's an anthropologist, just finished a whole series on Discovery Channel for the work that she does in Peru. We have many of the medical and nursing faculty who, through their churches and synagogues, work abroad in terms of their own faith-based commitments. And many of them have 20, 30-year commitments internationally. We have former medical missionaries who've lived in Africa or Asia for over a decade who are now on our faculty, bringing that perspective. We have folks in the music school. We have an ethnomusicologist whose research has to do with Greg Bars. I see some recognition. The ethnomusicologist, he's doing work in Uganda on how music and health are interfaced in traditional societies. I mean, I could go on and on and on about all the folks doing international work. We have experts in German history. We have folks with collaborations in China. We run a very large Shanghai cohort out of a collaboration between the folks in the Shanghai CDC and Vanderbilt, with 150,000 Chinese being followed over time. The men have been followed for about 8 years and the women for 10. Maybe I have that the other way around, but it's a long, study of diet, cancer, and heart disease. So I'm not the oddity, but I am the director of the Institute for Global Health, so I do get this kind of assignment with just obviously great pleasure. Many of you are familiar with the classic triad of academia, which we think of as teaching, service, research. But our Vice Chancellor for Health Sciences, Harry Jacobson, recrafted that in a way that I found very attractive. He talks about working in new ways, which is a variant of research, I would say. Getting results that matter, which is a variant, I guess, of service, and transferring knowledge, which is the training and education mission. The reason I like this flywheel, as Harry calls it, is because it is really, I think, a richer way of expressing that classic triad of teaching, research, service. And the ultimate desire is obviously impact on society. Now, on the international side, we're in a little bit of trouble because of global inequities. As you all know, the richest countries take electricity, formal housing, modern sanitation, and simple public health measures as clean water to the house. And I'm fidgeting, I'm making noise for the camera here. We take these things for granted. We've had advances in public health that happened all the way back to the 19th century that we take for granted today. This is not taken for granted in the poorest countries, in which a fraction of people can take those four things for granted. We also spend a spectacular amount of money on health care in the Western world compared to what the rest of the world spends money on. And as Christine Minja-Trupin from Meharry knows, having studied health disparities her whole career, we have this lack of awareness, I would say, in this country as to how vast the investment differential really is. The US spends nearly, well, about double this sum. So this is summarizing all high-income countries, but we spend a good $6,000 per person per year. The Europeans tend to spend about a third less. And then you've got the rest of the world, which is spending a tiny fraction. So the modern medical infrastructure that we take for granted is not taken for granted in most of the world. Now, I get this question from time to time when the people in the audience are honest enough to ask it, you know, because many of them are thinking it, but it's a tough question to ask. If you ask the director of the Institute for Global Health, it sounds vaguely insulting, but I don't think it's insulting. I think it's a good question. Why global health? Don't we have enough challenges in the Mississippi Delta, in Appalachia, in inner city Nashville? Don't we not have enough challenges with the Inuit population in Alaska, or the people living in the backwaters of the mountains of Puerto Rico, all of which are part of the United States? Well, the answer certainly is not a defensive one. Most of us who work in global health also work domestically, and we typically work in environments like this. There's a lot of synergy in the work that we do in, say, Appalachia compared to the work we might do, say, in rural Zambia. Because when transportation is a problem, it's a problem. When family resources are a problem, it's a problem. If you don't have health insurance, it's a problem. And these problems do cross borders, and there are many synergies. But some of the real proactive responses are you have a globalized economy, and it's a major overseas business for the US at the present time to enhance the globalized economy. We don't do well either in the state of Tennessee or any of the home states where you come from buying and selling from our US constituents. I've talked to business person after business person on airplanes, here at Vanderbilt, in social settings. Many of them will say our company would not be in existence today if we didn't have our overseas markets and if we didn't have our overseas manufacturing capabilities. So for us to stay globally competitive, we have to be international, which then engages us in global health, if for no other reason than for the workers who work for our companies overseas, or our corporate workers or executives who travel overseas. So there's a strong need for US business to be aware of and on top of issues of global health. We have a country, as long as our country has been in the wider world, we've had immigration and travel. There's a strong need for tropical medicine expertise for that, for those individuals. We've always had national policy commitments and spiritual commitments abroad. That can extend from military medicine, which is steeped in tropical disease expertise, by the way, medical missionaries, or persons who, for humanitarian reasons, would like to work internationally. Health and poverty are now seen as security issues in a way that they were not really appreciated previously. Whether that was 9/11, whether that was the global AIDS epidemic, what it is exactly that started us thinking along those lines, we do think that hunger and disease is more likely to breed terrorism and global insecurities and foster sort of dissatisfaction, as Thomas Friedman calls them in the Angry Young Men. The traditional reason for working internationally is it's the right thing to do. Preserve health, cure the sick and wounded, alleviate human suffering. That's on the lips of every nurse and doctor and healthcare worker as their sort of primary focus of being in the health professions. And then I think there are synergies with our own challenges in our country. Rural poverty, access, health disparities, immigrant health. Those words could be applied in the state of Tennessee, in the state of New Jersey, or in Mozambique, and they would all have resonant meaning. So I think there are a lot of reasons for Vanderbilt to be working at a broader world stage. Now, to move to the AIDS epidemic, I think you're all largely aware that the US epidemic is somewhere in the 0.3 to 0.5% of the US population is infected with the AIDS virus. That's probably a little more than 1 million people are living with HIV at the present time out of our population of somewhat greater than 300 million. In sub-Saharan Africa, it is between 15 and 35%. So if you get off the airplane in one of the capitals of one of the countries marked in very dark red on the slide, and you look around at all the young adults, it's 1 in 6 up to 1 in 3 are infected with the AIDS virus. That is an absolutely staggering disease burden for any infectious agent. We are not doing very well on prevention. This is just something that I cooked up with each dot representing 44,000 new infections from last year, according to UNAIDS statistics. And by the way, UNAIDS modified its, UNAIDS is a cross-UN agency, covers the World Health Organization, UNESCO, UNICEF, a number of others, to improve coordination around AIDS efforts. And they actually decreased their estimated numbers last year with some improved demographic methodologies. So these are conservative numbers. And every blue dot is a sub-Saharan African block of 44,000 new infections, and every green dot is the rest of the world, including Asia, and then we would represent the one red dot. So on a global stage, we don't look like much, although 44,000 infections, new infections a year, is really quite an indictment of how poorly we're doing, and certainly on a global stage, we're doing quite poorly. As you can see, sub-Saharan Africa, with 68% of new global HIV cases, only has about 12% of the global population. And that's another way of looking at it. The percent of adults estimated to be living with HIV disease. So this includes sub-Saharan Africa in lower prevalence areas. So this includes West Africa, East Africa, which have much lower prevalence. So that's how the 7% is correct, but the 15 to 35% is also correct. 15 to 35% referred to the further southern countries, Lesotho, South Africa, Swaziland, Mozambique, Zambia, Zimbabwe, Botswana, those. But if you include all of sub-Saharan Africa, it's about 7%, which is still dwarfing. Now, I think it's a surprise to most of you that the second worst epidemic in the world is in the Caribbean, particularly in Haiti, but also some of the other Caribbean islands are afflicted more than other parts of the world are. Well, there was one good, I don't want to get into politics. I was in North Carolina yesterday and I heard plenty of that. And I won't tell you who I would vote for or anything, but I will say, regardless of what you think of the current administration, a very good thing that happened, starting with the State of the Union address in 2003, was the creation of the President's Emergency Plan for AIDS Relief, or as we call it, PEPFAR. And Bill Frist here in Tennessee was very helpful. There were a number of Democrats who were very helpful. It was a broad bipartisan initiative, and to be perfectly frank, it shows the power of the United States of America for good in the world when we can get our act together politically and work, row the oars in the same direction. And I'm very proud of the United States for having initiated this. This is one of the earliest projects. When I was at UAB, I came to Vanderbilt 3 years ago. I was at UAB for 11 years before that, University of Alabama at Birmingham. And we were working in Zambia, still are, but I'm less involved since I'm here now. And that's what we were able to do with PEPFAR resources in 1.5 years. And I can tell you that if you screen 37,000 people, and that number is over 100,000 now. If you screen 37,000 people and 2/3 of them need antiretroviral therapy, you're dealing with a very advanced pool of patients. If we screen people in any venue in the US, the proportion who would need antiretroviral therapy immediately would be like 1 in 10. But there were so many people who were very sick that they came for screening, overcoming what I would call the stigma of society, which would, have relatives say, no, don't go for HIV testing. You don't want to do that. But we had no trouble. The floodgates opened, and what overcame stigma in Zambia and many, many other countries was the availability of therapy. Because it was true in the United States in 1985 that it was hard to get people to come for an HIV test, because what did we have to offer them if they were positive? The threat of losing their job. There were all sorts of negatives we could offer them, and the positives were sort of education, but we didn't have any therapy, and we didn't know much about the transmission of the virus back then. So it is true, when you actually offer life-saving therapy, people are much more willing to get an HIV test. And that took organizational talent, but it also took resources, and the resources are something that we didn't have. And that shows you the sickest of the sick patients. Your and my CD4 count, hopefully, is in the 1,000 range. If you have fewer than 50 cells per microliter of plasma, that is almost zero. That is an extremely advanced AIDS case. And those persons who chose not to go on antiretroviral therapy, ART, died at very high rates. Almost everybody was dead by a year. There were like 80% death rate within a year. So that shows you how advanced the disease is. Look at the blue curve. In a year, 20% had died, and almost all of them, I guess I don't have a pointer, but almost all of them had died very early. So those were people who already had advanced disease, including opportunistic infections, those infections that don't kill you and me because we have intact immune systems, but will kill somebody who has a devastated immune system. Now, not all of you are AIDS experts, in terms of knowing much about the virus, but suffice it to say that the virus is like the Trojan horse. It's brought into the city and it destroys from within. So the HIV is brought into the T lymphocytes that are vital for our protection as immune active cells. And so they actually destroy the cells that are designed to protect us. And how are you going to see something to destroy it if it's inside of you? It's inside the cell that is supposed to recognize it and destroy it, but it's inside. So the Trojan horse, to me, is a great analogy to the way that HIV works. So you can save the lives of even the sickest people. The gap between those blue and red lines, the proportion who are surviving, is what you see here, and the days are over here. So if you just focus on 365 days on 1 year and go up, and you see only about 20-25% of the sickest still alive in 1 year, whereas you see almost 80% alive. So that's how you read that chart. Now these are the number of cases of pediatric HIV in the United States. And they were on their way up, and they went down. Why did they go down? Because we instituted universal screening of pregnant women for HIV, and if they were positive, we treated them with antiretroviral drugs while they were pregnant, and also treated their infants. And we can knock the socks off of HIV, mother-to-child transmission. What we call PMTCT, prevention of mother-to-child transmission, is based on identifying pregnant women who are HIV positive and immediately giving them antiretroviral therapy, which reduces their viral load and massively reduces the risk to their infant. And that's what happened. We took a massive public health emergency in the United States and virtually eliminated it. So that's a consequence of research, drug development, public health implementation. So we can do a lot when we set our minds to doing so. Now in Zambia, this is a very busy slide for which I apologize, but in Zambia we used a drug called nevirapine, which is very long-acting and is especially good for prevention of mother-child transmission, PMTCT. And we wanted to maximize antiretroviral therapy coverage and efficacy. And ignore almost everything on this slide except the pretty little boxes in the middle. It sounds really easy to do this, but it's not so easy. And if you go to the top, you have to have women who have access to antenatal care, and you are able to then have them in your system. A lot of rural Africa, women deliver at home and they don't go to antenatal care. How are you going to prevent HIV in them, for their infants? Then you have to have a nevirapine and voluntary counseling and testing system, and you offer the intervention. And lots of women are going to say no. They're scared. They're often scared of their husbands, frankly. Then they have to accept the nevirapine and take it home because they need to take it on onset of labor. But then they actually have to adhere to the intervention, meaning several weeks later they have to remember to take the pill. And women have a lot on their minds when they go into labor other than take some stupid little pill. What if they misplaced it? What if they're at their mother's house across town? What if they, in all good faith, gave it to their sick uncle who was very ill and they naively thought that giving this pill to him would help him? I mean, there are lots of, maybe they're embarrassed to take it in front of relatives. Lots of reasons why women intend to take it, but they actually don't take it. If they don't take the pill, they're not going to prevent the transmission. And then you have to give the nevirapine to the infant. So if you've got dysfunction in your postpartum ward and the baby doesn't get the dose, that also reduces the efficacy. And we did a thorough program evaluation about which we wrote many papers, and we found that only 30% of the eligibles coming into that red box ended up successfully getting the full course of prevention. And that was much lower than we had thought. And so we were able to do programmatic improvement, and we seem to be improving by 10% coverage per year. We think we're up to about 70% by 2007. And now we've hit an asymptote where we're having trouble getting beyond 70%. So this is what we call operations research. It's where you know what to do, but you're not quite sure how to do it. And operations research is a big part of our program. So we started as Colleen knows, our dean of our nursing school, the Institute for Global Health. I need to talk to you, Colleen, because we've got to make this a university-wide effort.
I can't agree more. I'm interested in why, like 70% is you hit the wall.
Well, that's what we're interested in. We would like to know why we're not doing better than 70%. There are definitely some women who just don't want that test. And we learned through anonymous testing of discard cord blood. You know, when you have the umbilical cord, you're just discarding the cord and the placenta. So you can clamp the cord and draw blood from the cord without the baby suffering and the mother suffering. That's baby's blood. And you can tell whether the mother's infected. And the women who turned down testing were more likely to be infected. So there's coming often from somewhat dysfunctional household environments where they're afraid of their husbands. They turn it down because they don't want to engage the husband on this debate. And they're exactly the women who need it the most. So we're not sure why we've hit this asymptote. That's a topic of intense investigation.
I mean, you're talking about
partner, sexual partner. There's a lot of informal marriages in Zambia and Mozambique, and sometimes they're married, sometimes they're informally married, sometimes they're just sexual partners. So we founded the Institute for Global Health here. Right now it's in the medical school. I think it ought to involve at least 3 or 4 schools, and we ought to think about that. And then we also founded a limited liability corporation so we could do Vanderbilt's work internationally more efficiently, and that's called Friends in Global Health. And we've been licensed in Mozambique for our work there. So PEPFAR is intensively in the red-colored countries. Only 1 country in Asia, Vietnam, 2 in the Caribbean, Haiti and Guyana, and then the other 13 countries are as you see them in Africa. And we are working in Mozambique, which you know is near Madagascar. And that's Mozambique. You can see South Africa at the very bottom of the slide to the left, and Zimbabwe and Zambia, Malawi, and Tanzania. Those are the bordering countries. And we're working in northern Mozambique, north-central Mozambique, in a province called Zambezia province, sort of named the same way the Zambezi River is, which is just the border, the southern, I wonder if I can, here, I can use this. The southern border here is the Zambezi River, the mighty Zambezi, which is subject to flooding, by the way. And there's a lot of, when you read about Mozambique having flooding disasters, often it's where I'm showing you here. And our program office is in Quelimane, the provincial capital, and I'll also show you a slide from Alto Moloque. But we have staff, Vanderbilt staff, and faculty, 1 faculty member, who are working in Namaroj, Lugela, Ilhe, Gile, Morumbala, Mopeya. We're going to be going to Chinde. That's going to be quite an experience. The only way to get to Chinde is 12 hours by jeep or 12 hours by boat. So it takes you 2.5 days to get to Kiliman, and another yeah, you can take the boat. Another 5 hours to drive here. So we are in one of the more remote parts of the globe. In other words, when you think about 90% of the population of the world can get from where you live to where one of the other 90% in less than 30 hours, this is a good 50 hours from where we are. So it's somewhat remote. And our goal, the Institute for Global Health, is this classic service, education, and research mission, and we want to improve health status. It's that simple. We've gotten this award, and we're doing some things right because the CDC has bumped our funding from an initial $1 million to $4.5 million this year, and it looks like it'll be doubled to $9 million next year, so we're busy. We have a dozen expatriate staff, over 100 Mozambican staff. Alfredo Vergara here is heading this program, for which I serve as principal investigator, and this is our faculty member on site, Troy Moon. Troy has an MPH before he went to medical school, Master of Public Health, and did his training in pediatrics and pediatric infectious diseases, and he's our full-time clinical director in Kiliman. There are about 4 million people in this province, which makes it the most populous province of any in Mozambique. The background prevalence is at least 20%, probably somewhat higher than that. And that means there are at least 300,000 adults with HIV/AIDS in the province. This is a picture of Kiliman, which is on the Indian Ocean. Capacity building is a big part of what we're doing. We're increasing our program size to 3 or 4 rural sites per district. We have a site in the district capital, in the rural hospital or the district hospital, and then we're looking for satellite sites. We're working on a mobile clinic for which we're having trouble getting funded, but we've gotten our first mobile clinic donated by the Real Medicine Foundation, which is in Hollywood. And a very charismatic director of that foundation has raised some money from Hollywood folks and corporate folks in California, and they discovered our project, liked what we were doing, and said, how can we help? And the next thing you know, we got a mobile clinic in a district that we needed it quite desperately. We have incorporated primary care support. We really need to extend the scope of HIV-related health care to include non-HIV, because how are you going to sustain HIV programs if background primary care is pretty rotten? That's just not possible. I mean, we can do the HIV thing as long as people give us large sums of money. But to sustain it, when that money goes away, we're going to have to be rebuilding primary care infrastructure in one of the poorest countries, in one of the poorest provinces of one of the poorest countries in the world, and that is an essential. And we're expanding our technical advisory role. We're getting very involved in pediatric care and treatment, not surprisingly, given Troy and my background, and training support of the province. We've essentially adopted a training center which is in desperate need of assistance, and we're helping them. We've hired 2 former Peace Corps volunteers, by the way, who speak fluent Portuguese because of their Peace Corps experience, and they're working with us on that. And community outreach, including home care, because there's a lot of demand to care for people closer to where they work. You know, if you ask a subsistence farmer to take a day out of his time in the field to come to the clinic, and it takes him half a day to get there and a half a day to get back, he's lost a day of income. And if you make $1 per person per day, you can't afford to lose a day of income. So we need to start building our ability to carry our sustained programs to them. And then tuberculosis and HIV interface issues, including lab upgrades. As you know, an immunosuppressed patient is much more likely to manifest with HIV, with tuberculosis than a non-immunosuppressed patient. So TB rates go up when AIDS rates go up. And this is a typical road. You drive on the left in Mozambique, even though it's a former Portuguese colony, all of its surrounding countries are former British colonies. And very cleverly, the Mozambicans decided to switch and not fight, because you can imagine what the borders would be like if they drove on the right like the Portuguese, and all the surrounding countries drove on the left. So happily, they drive on the left. And this looks like a very perfectly good road. But let me tell you that if it takes us an hour to get between clinics in the dry season, it takes us 4 hours in the wet season. What will typically happen is the rivulet will not have the pipe under the road, so the road just washes out. So tremendous infrastructure problems. And for lack of the investment for that steel pipe to carry the water under the road, you wash the road out every year. And so it becomes very complex to negotiate that. You might say, well, why don't they put the steel pipe? And the answer is nobody is willing to pay for it. That's a typical rural clinic, very, very busy, very, very crowded. Even though you see the electricity poles right above the clinic, this clinic has no electricity. It has no running water. It has no toilet. And there is a nurse who has just finished nursing school, and it's not quite a nurse like you graduate, Colleen. It is a very junior and inexperienced nurse, and she is stuck out here alone, sometimes with a medico-technico assistant, a medical technician assistant who doesn't have nursing school, and it's often 1 or 2 individuals. They don't like living here. Their housing is poor. They don't have suture equipment. They don't have drugs. Maybe they get a drug shipment periodically. Within 3-4 days, it's gone. So they don't have much to offer, and morale is very low. So we show up and we help them expand their clinic, paint the doggone thing, get some electricity in. We've gotten permission from CDC now to spend some of our money on staff housing. And we can substantially improve the quality of life of the healthcare worker and at least provide excellence in HIV care and management, along with control of a lot of other infectious diseases. And we're working on funding for a broader panoply of primary care needs. Now, what are some of the challenges? Well, working in remote areas, you've got logistics issues, staff issues that are quite challenging. We have one of the world's lowest number of healthcare workers in Mozambique. Vanderbilt University has 6 to 7 times the number of doctors as does the entire country of Mozambique, which serves 20 million people. There are about 300 doctors in Mozambique. There are only 2 medical schools producing doctors, and they're producing doctors at a rate of about 30 a year each. And those 60 doctors have to provide community service. So the young doctors are in Mozambique and they go out, as the nurses do, providing their community service. As soon as they finish their community service, they move to the capital city of Maputo, which is a very agreeable Mediterranean-style city, and they make a living there. And there's a doctor shortage there too. And if they don't move to Maputo, they sometimes move to South Africa. If they can speak English or learn English, they often leave the country. So there's a tremendous brain drain. There is extensive training and ongoing support needed. There's inadequate clinical space and laboratory infrastructure, and there is a substantial bureaucracy in Mozambique. They were a Portuguese colony. When the Portuguese left, they did not leave a very good legacy of trained Mozambicans. And the new government turned towards the Soviet bloc and was communist for a number of years. There was a devastating civil war. And between the old colonial approach of the Portuguese, the heavy hand of communist authoritarianism, you have a legacy of a pretty heavy bureaucracy, even in modern democratic Mozambique. So we have to have approvals on top of our approvals on top of our approvals. So that's how we feel sometimes. We feel like we're about to tip over. It's not easy work. And we're, as I mentioned, obviously focused on HIV. That's what the U.S. government's paying us to do. But we know that if we don't get a handle on water and sanitation, economic agricultural development, educational improvements, a broad-based upgrade in primary care and public health, and if we can open opportunities for other parts of the university, we think we can get, Peabody, and some of you heard the previous speaker. We have one of the best education schools in the country, several of whose faculty are very interested in developing country education. We've got tremendous engineers, experts in water and sanitation. We've got fabulous nursing school, and I would have said that anyway, Colleen. And we've got anthropologists, historians. There's a lot of interest. We used to have a provost who was a Lusophone Africa specialist. Lusophone, you know, Anglophone, English. Francophone, French. Lusophone means Portuguese. So Portuguese speaking is a Lusophone country. And he was a specialist in the 5 countries of Africa that are Portuguese speaking. Okay, here's a quiz for our seniors. Name the 5 Portuguese speaking African countries. Mozambique, I gave you that one. Name another. Angola, very good. Name another. Wait a minute, that's not a senior. That's a distinguished faculty member at Meharry University. Cape Verde, and no more from you, Christine. 2 more. If you get these, I'll have to give you something. No, no, good guess. They speak Malagasy there. No. This is tough. This is tough. This is tough. There are some small islands off the coast of... No, no. Small islands off of the coast of Nigeria. No. Sao Tome and Principe, that's right. Sao Tome and Principe, somebody knows their geography. And that's another one. And then one that you'll never get, Guinea-Bissau, which is in West Africa. Not Guinea, but Guinea-Bissau. So 5 countries that were colonized by the Portuguese, and their lingua franca in each of those countries is Portuguese. Did you know that Portuguese language is one of the 6 languages that's been plucked out by the National Security Agency of the US government and the CIA as high languages of global priority for Americans to learn how to speak in the next couple of decades? There's 6 of them. Who wants to guess the 6th? The one you wouldn't have guessed is Portuguese. And why? Why Portuguese? Brazil, with its huge importance in the Americas, the 2nd largest country in the Americas, right, population-wise, after us. And then those 5 countries in Africa are all incredibly strategically located. Sao Tome and Principe is right in the belt of oil, and we do a lot of crazy things for oil. In Sao Tome and Principe is right there. And then we've got, in Mozambique, remember what I showed you, it's right there on the Indian Ocean, and then Angola's parallel right on the other side. And then Cape Verde is right off of West Africa. Maybe Guinea-Bissau is not so, but the Portuguese colonized all the corners of Africa. And that's seen by the security people as very important. We need very good relations with those countries. So that's Portuguese. What are the other 5? The other 5 are pretty easy. No, neglected languages. Neglected. So take Spanish and French off your list. Neglected languages that Americans don't speak enough of. Chinese, I heard, yes, correct, 1. Arabic, very good, 2, also a relatively easy one. Russian, 3, very good. The other 2, a little more subtle. Farsi, who's speaking? You're the Sao Tome and Principe lady. I'm paying attention. Farsi, the language of what country? Iran. And the last one, Hindi. Very good. This is a smart group. Hindi. Just the sheer magnitude of the number of people who speak Hindi. And by the way, spoken Urdu, the language of Pakistan, is virtually identical to Hindi. And a number of other regional languages are similar to Hindi, like Maharashtra. So you can learn Hindi and have it as a base for, now, you know, I speak Norwegian because of my heritage, so I can understand Swedish, Danish, it's like that. So there are a lot of opportunities for our university, and I think that we ought to grow this enterprise. Now, Alto Moloque, that's what the rural areas look like. Down there is one of the district hospitals, the main street of Alto Moloque City. And then I just want to point out one of our nurse practitioners, Janine Burleson, who is from Centerville in Hickman County, which is about an hour from here. And she was our very first employee, and she is doing extremely well. She was Peace Corps in Burkina Faso, and she signed up for 3 years, and she was, her 3rd year, she was relocated to one of their most isolated posts on the Sahel, because she was such an independent lady. And so with this track record of success, having learned fluent French during her time, She didn't speak a word of Portuguese. We sent her for 3 months of language training, and she is fluent in Portuguese now, and she was the nurse practitioner in our most isolated setting. She didn't even have cell phone access where she was living, which is really primitive. And even in Mozambique, we can get cell phone access. And now she's the head of our monitoring and evaluation group. Now, training and service is a no-brainer, right? But why research? Well, these are 5 questions that I'm posing to you. Does anybody know how to ensure lifelong adherence to antiretroviral drugs to treat HIV/AIDS? It's tough in the US to do this, to tell somebody they need to stay on antiretroviral drugs for the rest of their lives. It's very, very tough, especially when people with HIV may be somewhat disenfranchised from the mainstream of society, injection drug users, for example. You know, many of our gay men who used to get HIV in the 80s were relatively well educated. Many of the gay men who get HIV today are not so well educated. Proportion of African American gay men who are representing a big proportion of the epidemic is much higher now than it used to be. It used to be white gay men. Now there are many more African American gay men. These are not people who are necessarily in the mainstream of society. So if it's tough for Americans to take their drugs, can you imagine a poor Mozambican farmer? There's no tradition of lifelong chemotherapy for any condition in rural Africa. If you get diabetes in rural Africa, you will die of your diabetes. You will not have any access to insulin for the rest of your life. And so there isn't a tradition of taking pills for the rest of your life. So people tend to take them for 2 or 3 months. They feel better, then they stop taking their pills. Now the viral load rebounds and they get sick again. Now they get sick with a resistant virus. So it's a big problem, and we think it requires some research. Now, it may be research that involves our anthropologists and our nurses. We need to get some insights from different disciplines. It may not be research that doctors should be doing all by themselves. Now, who has the best plan for affordable strategies for handling opportunistic infections in poor countries? You know, opportunistic infections often require very expensive drugs to treat them. So how can we prevent them instead of having to treat them? What impact are we having with our program? Just operations research, evaluation research. Sure, we can throw a lot of money at it, but someday Congress is going to ask, what have you gained with this money? And the American taxpayer is going to ask, was this a good investment? So it's up to us, the implementers, to be able to document the extent to which we're doing well or poorly. Plus, we can improve our own programs, as I tried to show you with our PMT-CT work from Zambia, where we ourselves did our own evaluation, found out we weren't doing as well as we thought we were doing. Well, that helps us reform our program and improve it at every level of the cascade, and we can do better. Do wraparound community development programs increase PEPFAR effectiveness? Maybe the most important thing to increase adherence is to improve family income. Make it easy for somebody to miss a day in the fields because you've helped them with a fertilizer program that's quadrupled their crop yield. So maybe it's the microloans, getting women to open up a sewing service and bring in that discretionary money into the impoverished household that will make a difference in helping people stay on their antiretrovirals. That's personally what I believe. But we've got to demonstrate it. And what community projects are actually making an impact? So these are the sorts of research questions. They're not very highfalutin research questions. They're not trying to find a gene therapy approach to cure pancreatic cancer. They're very applied, field-oriented research questions. And it is very gratifying work, I have to say that, for all of us. And why Mozambique? And that's the main reason. It's really a privilege to work on a historic battle against the world's worst modern epidemic. And in the most afflicted areas of southern Africa, death rates rival those from 14th century Europe. You'd have to go to the history books and read about the 25% death rates in Europe from the bubonic plague in the 14th century to get anything that approximates what AIDS is doing to southern Africa at the present time. And the U.S. is playing a leadership role now with strong bipartisan support in this global battle. And Vanderbilt is tackling one of the toughest challenges, namely rural care in one of the poorest nations in the world. Now, we didn't do this by accident. We did it because we volunteered to do it. And we did it because the other universities had cherry-picked the urban sites and some of the more pleasant places to live, and we realized that if we embraced Zambezia, we would have no competition, and we have no competition. But that creates enormous, well, Colombia is one of our partners, but we are in a good position to grow our enterprise if we do well, and I haven't had trouble recruiting. We have 4 nurse practitioners, 1 nurse, 3 doctors among our expat staff. I have a marvelous health educator from Brazil. We have put the word out that these jobs are available, and you'd be surprised the people that have come to apply for these jobs. Experienced, qualified people who could be working in all sorts of environments, but they are taken by the challenge of AIDS in Southern Africa and they want to do something about it personally. So we have an amazing pool of individuals. So obrigada is what a woman would say to a man would say obrigado in Portuguese. It simply means thank you. And when you hear that from a woman like this with her baby on her back, it's very gratifying work. So congratulations to all of our seniors, and that's my email at the bottom, and I just want to open it up for Q&A. Any questions or comments? Yes, please.
Have you been able to pinpoint where in Southern Africa the epidemic sort of began? And it looks like it's spreading all over.
The question is, have we been able to pinpoint where the epidemic began in Africa? Well, it did begin in Africa. The genetic evidence is overwhelming. And a molecular biologist actually at University of Alabama, Birmingham, Dr. Beatrice Hahn, has done perhaps the best work. And she has gotten retroviruses, HIV is a retrovirus, specimens from chimps and monkeys from Central Africa. And there seems to be clear genetic evidence of a divergence in Central Africa. So around Gabon and Central African Republic and northern Congo, that's probably the region of the world where HIV emerged. It was probably a zoonotic disease, namely a disease of vertebrate animals that was transmitted to men. It probably got into man through hunting. And if you are a hunter going through the bush and you hunt a monkey or a chimpanzee, which is commonly done in that part of the world, for food, you then will be skinning that animal, and that's a very bloody procedure. So there's all sorts of opportunity to cut your hand in the effort to get the animal, and then there's all sorts of opportunity to bathe your hands in the blood of the animal, and that's the most likely explanation of how HIV got into humans. Sadly, when it got into humans, it stayed in Africans for probably 20, 30 years before ever jumping to a global scale. And it stayed in rural Africa at very low levels. We know that from stored blood specimens from projects, tropical disease projects dating back 30 years, where somebody, you know, in the Yale Arbovirus Lab or somebody at the CDC or somebody at the NIH had actually stored the specimens for 30 years. They went then back and tested, and they found about 1% background prevalence. But with traditional mores of traditional societies, you didn't have a lot of transmission because you didn't have a lot of promiscuity or drug use. Once you made the leap from conservative lifestyles into modern lifestyles, and you started dealing with people who have multiple sexual partners or people who share needles, then it spread like wildfire. Now it's so prevalent that you don't have to be at very high risk. If you're a young woman in sub-Saharan Africa, you get married at age 17, and your husband is 23 years old and he's had 3 or 4 other sexual partners before, he may very well be infected. So the #1 risk factor for women getting HIV infected in sub-Saharan Africa is being married. So women cannot characterize their risk based on traditional risk factors when the background prevalence is as high as it is there. Just having sex with somebody puts you at risk when the background prevalence is 30%. Thought I saw another hand. What about my Farsi Sao Tome and Principe lady? No questions? Come on. Yes, sir. Here.
I know the Clinton AIDS workers tried to drive down the price in Africa.
That's correct. There are two two groups that have been very influential. First, it was Médecins Sans Frontières, as we know at Doctors Without Borders, and they were very brutal on the drug industry in the late 90s. And then the Clinton Foundation didn't do as much public humiliation as Doctors Without Borders. They sort of went with Bill Clinton's sort of prestige and negotiated these very low prices.
My question was kind of, has the price issue disappeared from that, or is it still a critical piece?
The price issue has virtually disappeared. You can now buy a year's worth of triple drug for about $130. And that puts PEPFAR, that puts antiretroviral therapy in the same category of cost efficiency as infant immunization or oral rehydration for infant diarrhea. I mean, those are two of the cheapest things we can do internationally. And when you look at the years of potential life saved and you look at the social benefits, what you've got is a very sick man and a soon-to-be sick wife. The man dies, they lose the breadwinner. The woman dies, they lose the parent. So now you've got, at the first step of the deterioration of the family is the loss of the breadwinner or the loss of the mother or the child care provider, and then the next step is the loss of the other one. And then the kids are inherited by a grandmother who just got the 4 kids from her other daughter who died, and now her son has died and she's trying to inherit 3 more. So she sends the 12-year-olds out for a street lifestyle. She can't feed them all. So she sends the ones out who can forage for themselves, and the rest are at home. And I've seen unbelievable changes in Africa. My first trip to Africa was 1989 to Zaire. And Zaire was a very troubled country in 1989. And I went again in 91. It was still very, very troubled. We were doing some early AIDS work there. And as troubled as it was, as impoverished as it was devastated by its horrible government, you just didn't see kids out in the street at night. They'd be, in the day, they'd be doing various economic enterprises, everything from selling things to begging or just hanging out. But at night, they were home with their families. Same with Lusaka as late as 1996 or so. Today, you go to Lusaka. Today, you go to Kinshasa and go to one of the big crossroads of the street. You'll see kids prostituting themselves. You'll see kids sniffing a substance that they take animal feces and various gas products, and they'll sniff it to kill their hunger pangs. It breaks your heart, absolutely breaks your heart. There's been a severe deterioration in the family structure of Africa, because Africa was very family-oriented for all, right, Christine? I mean, if you had any kind of extended family at all, they would pull in an orphan. And you could be a distant relative, they'd pull you in to your family structure. You didn't have homeless kids the way we see them in the US or in Brazil or in Asia. Something about the African culture. And now you see plenty of homeless kids. Yes?
What percentage of your time are you able to do field work?
Well, much to my wife's chagrin, last year I traveled about 6 months out of 12. I try to keep it to 3 to 4 months, just for family purposes. But last year was a big year for us in terms of growing our enterprise, and it required a lot more field attention. We have our staff abroad, but most of them are frankly young. You know, it's harder to recruit a 50-year-old with a family to go to Mozambique than a 30-year-old without a family. So we do, sometimes we recruit the 60-year-olds without a family because their families are grown up. But so they do require some assistance with the experience that some of us have.
So these people that are able to go, are they in the field of science? They already have credentials?
They're very often practitioners. I wouldn't necessarily go to Zambezia if I were a scientist per se. If I wanted to apply my scientific skills to upgrading laboratories, for example, I'd go. But our opportunities to do fairly elegant research are few and far between. The nature of our research is very applied, very pragmatic, very operational. So we don't tend to lure the scientists per se. We tend to lure practitioners who are interested in a university affiliation as a backbone for their international work.
Are you simultaneously looking to improve infrastructure like water
Oh yes, I think I mentioned that briefly, but there's not a single rural hospital or a health post where we're working where we're not renovating. By the way, the U.S. has a very, very strong development philosophy that the United States Agency for International Development, USAID as we call it, has a very strong bias against bricks and mortar development. The bias in our culture is that humans make a difference. So we have no trouble getting training dollars, drug money, you know, for the pharmaceutical products. That we'll be able to buy Jeeps, we'll be able to do all of that. You ask the US government to pay to renovate a hospital, and they will never allow you to build anything de novo. You have to renovate. So I've been known to take a couple of bricks over in the corner and call it a renovation, which I'm flirting with US legalities. But if we have no place to see the patients, and it's only going to cost me $3,000 to build a little building to see the patients.
Yeah, I might add also that the School of Nursing has started a second track in our PhD program in health services research. And the focus of that is going to be very pragmatic of what works, is it cost effective, is it cost efficient, that sort of thing. And we hope to migrate that also to a non-nursing degree that would be available for folks who are interested, who are not nurses, but are interested in some of the same questions.
Very good. Well, this will be the last word because I think I've gone over my time considerably, for which I apologize. I wasn't.
Graduates and students.
Okay, good, Colleen. Thanks. Good to see you. Yes, ma'am.
My question was about sort of where you see your organization going. You see expanding beyond HIV in Zambia, or you would rather expand into Mozambique and beyond the country around that?
Well, in Mozambique, our work is HIV focused because that's where the money is. We have no illusions about the importance of primary care in general and wraparound programs, as we call them, the microloan, the agricultural. We would very much like to secure funding for a broader panoply of activities. That funding is not currently available, but we're not going anywhere. We're going to be in Zambezi for a long time, and we'll be working on securing broader funding base to build a more sustainable program. So that's my answer to Mozambique. But in other parts of the world, we're very deeply involved in non-HIV work. We are working on cervical cancer prevention in India, for example. We're working on drug abuse treatment and prevention in China. We've got a tropical disease initiative in Peru. We are getting involved in chronic diseases in a partnership with, some of you have heard of United Healthcare Company, one of the larger healthcare companies in the world. They have a branch called Ovations, which has made a donation to create centers of excellence in chronic disease in 8 different sites around the world. And we've been asked by National Heart, Lung, and Blood Institute to provide support for those 8 sites. So we're going to be involved in chronic disease, everything from smoking risk reduction in developing countries to obesity. We had a medical student working in Lima a couple of summers ago on just a quick and dirty 8-week project. And she was doing a nutritional survey of women in the poorest slum area of Lima, Peru. And 90% of her women were overweight or obese. Only 1.5% of the women were underweight. So there's been what we think of as an epidemiologic transition in many parts of the world. In middle-income countries like Thailand, Brazil, South Africa, and also in urban areas, even of poorer countries, a lot of the health problems that people are seeing now are similar to the health problems we're seeing in the US, which has to do with diabetes, overweight, this sort of thing. So there's a very intense need to focus also on chronic diseases in developing countries. And on that note, I thank you very much.